A quick note before we begin. This podcast dives into real, often raw conversations about life's most profound moments, from a labor's beginning to life's end and all the complexity in between. Some stories may be emotionally challenging or deeply moving. Please listen with care and know that you are not alone. Welcome to the Mamatoosa podcast. I'm your host, Atusa Benji. Hi, and welcome to the Mamatoosa podcast. My guest today is Dr. Adrienne Youdim, who is just the epitome of grace and kindness and knowledge and wisdom and evidence-based practice and everything supportive of, in my experience, womanhood. In my lifetime, I've seen many, many physicians, and I've seen many specialists and many experts, but there's only a handful where you can sit in front of them and feel like they are the expert, but they actually feel you. And there's like a heart-to-heart connection that goes beyond, I have expertise in this and do this, and here's your sheet and go home and I'll talk to you later, because it's just what you emit and who you are. And I'm just deeply grateful that you and I met. Dr. Youdim is a family practice doctor who specializes in obesity and nutrition. Recently, she also got her fellowship in mind-body medicine. She goes way beyond calories in and calories out. And most recently, I listened to her TED Talk, which was really, really important for me at that phase in my life, where she said, I always had a prescription pad next to me until I began to realize that obesity and our relationships with food go so much further than the medication I can prescribe to you. And many times it's easier to prescribe the medication than to actually get to the heart of what are you hungry for? So welcome.
Thank you.
Welcome.
Thank
Why
you.
did you become a physician?
You know, it's funny. People ask you, and I wish I had this fabulous story. I just always knew. I always knew that this is what I wanted to do since I was very young. Of course, I grew up in a family where, education was important, academics was important. But I really think that in terms of my upbringing, it's kind of this marriage between my father, who is a PhD and embodies that side of education, academics, and my mom, who was also a very hardworking mother. She was not a stay-at-home mom, but embodied the importance of nurturing, nourishing, always present, always cooking, always gathering family, friends around a table and a homemade meal. And so I think what I do really embodies that desire to have knowledge and expertise and really a fascination with science, but also the desire to be nurturing and to heal from, as you said, the heart-to-heart perspective. So I appreciate that you shared that and for your kind words, because it really is intentional.
And it's very much received. It did not go over my head. I ended up sitting in front of you because, I've had a weird body image, food and body stuff since I was a kid, which I think has many reasons. I think there's a huge genetic component to just food addiction and propensity to gain weight and be in love with food that's feeding a hunger more than just hunger, but trying all the different things. Let me try the Jenny Craig, and let me try the Weight Watchers, and let me try this, and let me try that. And when I sat in front of you, what I loved was we discussed medication. And then when I said, you know what, doc, I don't want to go that way, you were like, great, there's other options. Which is so refreshing, because so many times you sit in front of a physician who offers something, and then when you say no, or I'll think about it, doctors sometimes get offended, and I didn't receive that from you. So I'm wondering, is that inherent in your personality, or is it something you learned over practicing with people over time?
I want to go back first to where you started, because I think a lot of times people assume that an emotional relationship with food is unique to them, or perhaps if they're in a time in their lives when they're struggling with their weight, that emotional relationship with food is unique to that time frame of their life. The reality is that, emotional eating is something that's hardwired in our DNA. From, what you do in terms of birthing, that the very hormone, oxytocin, that helps bring in the milk, that helps mothers nourish their children, is the same hormone that helps facilitate love and connection between mother and child, and mother and partner, or even us with our pets, for that matter. It's important for me to bring that up because I think there is a lot of, culturally, I think shame is wrapped up into this notion of emotional eating or food and our emotions, when really it's part of our physiology, that connection between food and nurturing, food and love, food and connection. Right. And I think that's perhaps by design.
It has to be, because imagine, the quintessential thing that a girl does after a breakup is pull out a gallon of Haagen-Dazs, right? And it's cliche, it's silly, but when we come out of the womb, whether we come out vaginally or we come out abdominally, if the person who birthed us wishes to breastfeed, then that first milk that comes out is really high in sugar and super warm and super creamy. So we literally come out of like, wow, what just happened? I went from this warm, cozy jacuzzi to the bright lights of an operating room or life on the planet coming down a vaginal canal. And what do? You immediately give me something warm and sweet and cuddly. Then we're almost wired for Haagen-Dazs.
We are wired, and that is not only in the respect that you describe, but also, we can talk about dopamine, and this will take us another tangent,
an addiction, and
right. But the way in which we get primed by sugar, by fat, by salt, and how unfortunately that has been hijacked in the food industry to create, now whether you want to call it an addiction or not, I can speak to the pros and the cons of that kind of labeling. The point is, I want to just normalize it. I want to normalize the relationship we have with food. I want to normalize the difficult relationships we have, particularly as women, as our bodies change throughout the lifespan. There's puberty, there's pregnancy, there's menopause. Our bodies change, and we're not taught to accept that change, that normal fluctuation that comes with different life stages. And I guess that brings me back to your original question, which is that every individual presents with their own unique blueprint in terms of where they are in their lives, what their past experiences have been, and what modalities are useful to them, whether it's a pharmacologic or a therapeutic modality, what resonates, what lands, because that level of trust and buy-in, so to speak, is so important when we're talking about a lifestyle, right? This is a condition, and I even use that word with a little bit of trepidation. We define obesity as a disease, medically, or this is something that's since 2006, the American Medical Association defined obesity as a disease. On some level, that's great because it validated people's experience. Once people get to a certain degree of excess weight, there are physiologic reasons why it's so difficult to lose weight, why the body protects and defends that higher weight. And so for particularly a problem in which there's so much shame and blame and vilification, being able to say, hey, this is not a character flaw, this is a disease, on some level can be validating. But then on the other hand, I think we have to be careful because it also takes away agency. If somebody feels that they have an addiction or they feel like they have a disease, that's kind of a condemnation and takes away the aspect of free will. So that brings me back to, the buy-in. And if somebody is not aligned with using medication or the other way, and they're really thinking that medication is the right strategy for them, and they don't have that tool at their disposal, it's not only a therapeutic error in that they don't have the tool, but it's also a barrier in terms of their mindset, their buy-in, their ability to fully engage in the process.
For sure. For sure. It's interesting. As a midwife, I often come across that too, because if I have a client who's sitting in front of me with anemia, there are clients who are like, I am absolutely not taking ferrous sulfate off the shelf. It's chemical. It makes me constipated. I'm not into it. I'm not interested. I would much rather do your natural protocol, which is the beet juice and the liver and the proteins and herbs that I give them to bring up their iron levels. I get complete buy-in. Next thing I know, they've bought a juicer, they're mixing liver with their hamburger meat, they are eating raisins and, things that will bring up their iron, and they would never have done what may have been a faster way to just go and just pick up some iron off the shelf, and vice versa. For someone who's like, beet juice, like no liver, absolutely the heck no, I'm not, or whatever thing I recommend. If I don't have the buy-in, I'm not going to help that client therapeutically. So I love that you are mentioning this because it's so refreshing to hear a physician say that.
I mean, ultimately, we have to meet people where they are at. And I would say that even for the individual, it's their job to meet themselves where they're at as well.
For sure.
And a lot of times when it comes to weight loss or the lifestyle changes that we advocate for to help people lose weight, people will want to go from like 0 to 160, right? In a minute. I want to clean up the diet. I want to get rid of all the processed foods. I want to only eat lean meats. I don't want to have carbs. I want to exercise, 1 hour at a time, 5 times a week. And that is not achievable for many at the outset. And that desire, or it's more than a desire, it's like the conviction that it has to be that way, ultimately sabotages them from the attempt. And so even individuals have to meet themselves where they're at. And if your meeting place is strapping on those shoes and going out for a 10-minute walk, then that's where you are at. Because if we wait for that 1 hour to come or the 5 hours a week at a gym, right?
It may never come.
It may never happen.
And then you fall into the shame spiral of not meeting the goal that you reach. And that brings me to another thing is that I sometimes, while I struggle with this sort of middle-age phase of my life, there's something about being a grown-up now at the age of slightly over 50. I have an advantage that I didn't have when I was a young, heavy person. Because as a younger person who battled with 10 pounds, then 20 pounds, then 30 pounds, then up and down and up and down, up and down, there is something about this phase of my life where I know myself really well. So when I'm scrolling Instagram and an expert rolls up and is like, I ate cottage cheese pancakes for 45 days and I lost 45 pounds. I'm like, Or I scroll and there's something else. I scroll and there's something else. I can sort of smell what doesn't work for me very quickly. Whereas I feel like when we're younger, sometimes we're often our parents are making a lot of decisions. And then social media impacts us even more because we're young and that frontal cortex isn't fully developed.
Definitely.
And so to be a heavy teenager, prepubescent child it's hard. It's hard socially. It's hard mentally. It's not really accepted. And just as an aside, what I recently read, which I'm sure I had read somewhere during my schooling, but just came up again, the number one medical bias that affects care, when a physician enters the room and there's a client on the bed in an ER is what?
It's obesity.
Obesity. It's not color. It's not gender. It's not socioeconomic. It's boom. That's an obese person.
And here's the interesting point that these terms are now fraught with a lot of limitations, right? Like
sure.
Obesity and BMI or body mass index, which is how we define obesity.
Yeah.
And so let's use it, take it with a grain of salt.
Yeah.
But if we were to go based on that like hard and fast rule that a BMI or a body mass index of 30 or greater is considered obesity, then 40% of the population would be considered obese, and over 70% of the population would be considered overweight or obese. And so it's funny that there's a bias there when the majority of the population on some level could be considered to have somewhat or some degree of excess weight. But what I think is also fascinating is that even people who are normal weight are met with this conundrum. Even people who are underweight. Something that you said in terms of knowing yourself made me think of this term of positive self-acceptance, which is something that, the ability to accept yourself as you are in that moment. It doesn't mean that you don't wish to change, that there's nothing aspirational, right? We may want to grow, improve, all of those things.
Right.
But there's a posture that we can have that is self-accepting, which, by the way, is associated with successful habit change and successful goal achievement, meaning that if you want to do something different about yourself and you meet yourself with that posture of positivity, you're much more likely to succeed. But I digress for a moment, because what I wanted to tell you is the studies show that women, particularly girls and women, but we see this in men as well, have this negative bias towards themselves, even when they're normal weight, even when they're underweight. And there's studies that show that upwards of 80, almost 90% of girls, regardless of whether it's rooted in reality in terms of excess weight, upwards of 90%, they have body image issues, which is not representative of what's even real.
What's happening?
I am in general moving away from the terminologies. I used to think like we have to use the word where it, we have to make the diagnosis. And in a way it was important again, because I think it determined treatment or, their candidacy for certain drugs. And also I was viewing this issue from a very medical lens. Yeah. And now, while I still see patients, I still prescribe medications for weight loss and do all the doctory things. Yeah. I view this from such a different lens that I'm very mindful as to how our words and the labeling, how that impacts the person, the receptiveness to the treatment or to their own ability to change and to evolve. And I'm finding more and more that those labels are limiting as opposed to being valuable in any measure.
And it really is a four-legged stool. In my opinion, your health is emotional health, physical health, spiritual health, mental health. And if one of those legs of the stool is way higher, then the stool is going to topple over, right? So it's very hard for all of us to have all of the legs at the same level all the time. Sometimes we're feeling super spiritually elated. We're feeling really close and connected. Sometimes we're on it. We're walking every day and we're drinking our water and taking our supplements. Sometimes we're in an emotionally really good place. But I think the goal in order to be balanced is that four-legged stool that is just teetering on each one being the same height. And what we lose, I think, when we go to whichever diet person, diet club, diet thing, diet app is really only addressing one of those legs, which is physical. And I think I myself have joined Weight Watchers maybe 37 times in my 51 years on the planet.
I did Weight Watchers.
Yeah. And I was sent to Weight Watchers when I was 13.
I was young too.
Over and over again. The funniest story about that is that my aunt, love her, she was trying to be helpful and would give me the $7 to go to the Weight Watchers meeting, and I wasn't losing weight. So she couldn't quite understand, like, why was this not happening? So after a little while, I stopped going. Years later, I sat down with her and I was like, I am so sorry. I was an adult with kids. I was like, I owe you so much money. She's like, what for? I was like, remember all those $7 Weight Watcher meetings? She's like, yeah, that didn't work for you. I was like, no, because I would take the $7 and I would go to the convenience store during the half-hour meeting and I would eat whatever I wanted and then you would pick me up. So I think I owe you like $500 in exactly $7
pre-inflation or pre-interest rather.
Totally. Now it would be like 1,800. And I said, can I pay you back? Like, what can I do? She's like, yes, you can. She's like, you're going to take me out to lunch so that I get to see you and you're going to pay until you're paid up for all those Weight Watchers meetings. So from a young age, there was this like, get on the scale, there's something wrong. Get on the scale, there's something wrong. But the tangent, what I was trying to say was that Weight Watchers evolved over the years, and I'm not promoting Weight Watchers. Do whatever, you feel is right. But slowly they started incorporating the more balanced meal plan. Then they started looking at fiber. Then they started looking at exercise. And then they started incorporating coaches that would like talk to you through your feelings. Then they started creating like groups you could set up a group of Weight Watchers. So even Weight Watchers like realized that, hey, y'all, this is not just about exchanges. And back in the day, it was exchanges. You had like little boxes that you completed. I had my meat, I had my milk, I had my veggies, I had my water. They realized it's not just about this. So we know it, but what are we doing about it, essentially? And I think that for you and I, what we do share in common is our culture, which is, I believe, based a lot in the fact that our people have always been trying to show that we're doing better than we are. We have always had to hold a facade of, we're holding it together here. Like, we're good. I often share the story of this woman who, she was an older lady, used to come to our house and talk to us and said her husband died and left her with like 5 young children. And in order not to be looked down upon, or for people not to think that she couldn't feed the kids, she would put stones inside water on top of the stove or on top of the fire so they would boil, so that when people came over, they thought there was food in the kitchen. And I use that as a microcosm of our culture in a lot of ways, because I believe that as a result of our history, we have had to marry off our daughters, because a lot of times a young girl at home was expensive. She had to be fed, was another mouth to feed, or was at risk of being taken, raped, taken away. We would never see them again. So a lot of times parents had to offload their daughters in our history. And I think that created a reason or a tendency for us to want our daughters to look a certain way. So when I talk to my mother-in-law, who's now 101, God bless her, she will say, I was way too skinny for the family I married into. They kept giving me beer so that I would gain weight because skinny was not in. She said I was tall, I was slender, it was not a thing. And they literally fattened me up. Because in those days, a girl that was skinny, it seemed that her family maybe didn't have money to feed her. So we didn't go for the skinny girls. You went for like the fuller hips that could bear children, rosy big cheeks that meant she came from abundance. Okay. Now that's changed. Now, where we're sitting in Los Angeles, if your daughter is one way or another way that doesn't fit the paradigm, that child has already picked up that message from way deep before anyone even talked about it, that her body wasn't quite right. Now, confound that with puberty and stress and all the things that our youngsters are going through right now. And 3.5 out of 5 women have gone through some sort of sexual assault in their life. add that to the mix, and that's what's documented. That's what's reported. I would say it's closer to 4.5 out of 5, to be honest, especially in the field that I work
Right.
with. Many women have had some sort of sexual assault, which we know affects our bodies. We know affects our the way we look at ourselves and the way we feel in the world. But all that to say, we're getting messages about our bodies way subliminally before our intellect can take it in, that something's not quite right. And I remember being the topic of discussion of like, what are we going to do about it? I'm getting a little heavy. Like, in the meantime, we served food in platters.
Yeah.
We don't serve one piece of chicken per person. We put 6 chickens on the table.
I mean, there's so many paradoxes there.
So many.
And there's so many variables there. I mean, there is the cultural piece. There is the societal norms, what's trending in that era. But then, there's these other components. I mean, you mentioned sexual abuse, and there's such a clear correlation between trauma and excess weight or obesity. And it's not in the way that you may think. So, many people think that the link between trauma and excess weight is that if you've had some trauma in your life, then you're more likely to be dysregulated or perhaps depressed or have some emotional or mental distress as a result. And then you're using food to cope or to soothe. Mm-hmm. But we now know that actually trauma impacts the genes. Mm-hmm. So while we have genes that code for certain hard, what we call phenotypes, like black hair, blue eyes, for certain specific traits, there's parts of the gene, which is actually 95% of the genome, which is the management part, the part of the DNA that turns on or off the expression of the gene that codes for a trait. Does that make sense?
Yeah, of course.
So the trait, the actual DNA that corresponds to a trait is about 5% of the total genome.
So it's like a catalyst.
Correct.
Wow.
Or an impediment. So this turning on or off of those traits is actually guided by something called epigenetics, right, which is the environment's effect on whether or not that gene is going to turn on and off. Right. What they found is that trauma actually impacts our genes in an epigenetic way. So that if an individual has certain trauma, sexual abuse is one of them, but verbal abuse is another one. Mm-hmm. And I always laugh when I think about verbal abuse, because verbal abuse is also, I think, something that's so culturally laden. Mm-hmm. What in American culture is considered verbal abuse is like any given Tuesday in like in Iranian culture or Chinese or many cultures that immigrated to the United States. Yep. Nonetheless, different traumas, alcoholism or substance abuse in the home, incarceration in the home, physical, verbal, or sexual abuse in the home, all of these things,
the adverse childhood experiences,
correct,
right,
impact our DNA as well and our likelihood for a whole host of diseases, including excess weight. So, my gosh, I mean, this whole issue of our relationship with food, our relationship with our bodies, our likelihood or propensity to have excess weight is so complicated and is laden with so many layers. Yeah. And I think it makes it even more imperative for someone who's treating this condition or dealing with people who are struggling with their weight to really be open, mindful, patient, because it's not a one and done.
For me, I'm very open on the Mamatoosa podcast. Most people know my story. My mother literally dropped dead when she was 38. And, just dropped. Like, she was holding what she was holding and she went down. Wow. And came home from school and I found her, and it was devastating, and things were very, very hard for me as a teenager. She was always battling with her weight. Up and down, and she was always short of breath. And this was in the 80s in the countryside of England. So no one really thought of heart disease for someone in their 30s, female. So right. I believe she might have had an underlying heart something going on, which I believe, and I believe because it's just intuitively what I'm thinking, always diagnosed with asthma. So she kept taking these inhalers, which actually did nothing for her shortness of breath. So by the time she had found another, rest her soul, I know you're watching up there, another method to lose weight, she was doing shots. And I believe it was, is it HCG shots?
Yeah, HCG.
And eating like 500 calories a day. So what we believe and what I talk now to my cardiologist about, because my heart gets checked all the time and is, thank God, fine. He believes either there was some sort of congenital something going on with her heart, or the lack of calories threw off the electrolytes and caused her heart to just shut down. It was electrical because she passed so quickly. So I have very strong evidence, anecdotal evidence from myself, that dieting it's just so much more than that method. It just comes from the whole picture.
I mean, let's back up for a second and talk about, I mean, before we can talk about the food and the diet and the nourishment, let's talk about the hunger.
Absolutely.
And I love this question of what is it that you are hungry for?
What are you hungry for? I have a quote from your book, which I wrote down, which I love. Quote, "It's not broccoli we are hungry for. We're hungry for self-love and self-acceptance, for belonging, for connection, approval, presence, and autonomy." Woo! From your book. Tell us the title of your book.
Hungry for More. And I'll tell you where this came from. The whole concept of the book. Again, back when I started, as I mentioned, I was young. I had put together this concept for a medical component to a weight loss program. There was a surgical weight loss program, but there wasn't a robust medical program. And so here I come in and I say, we should join forces. There should be nutritional counseling pre and post-op, and we should have a medical option for non-surgical patients. And I'm in a, ivory tower institution. I'm the youngest female medical director at the institution. I'm working with primarily males and male surgeons. Mm-hmm. And, I felt like I had to be very doctory. And so I'm prescribing medications to suppress people's hunger,
right,
so that they can lose weight.
Yeah.
And what I'd realized is that all this time I felt that there was this other hunger in the room. There was a spiritual hunger, an emotional hunger, and that this hunger was not meant to be suppressed. That this hunger was actually a signpost that we needed to lean into. Being at Cedars and having the position that I had, and being as young as I was, I didn't feel I had the autonomy to address that, to explore that with the patient. And it took leaving my post, quitting my job, leaving that practice, going out on my own, to be able to practice medicine in the way that I really felt was right. And I really leaned into this question of exploring the hunger. And I would hear patients come in with story after story after story, always laden with shame. And me, on this side of the desk, felt like I was the benefactor of all of these stories, and recognizing that there was this universal thread connecting all of these people, right? Yeah. And that what Jackie said was so similar to what Susan was experiencing. And by the way, the guys were experiencing the very same hungers. And
as a human,
I was too.
Yeah.
There was nothing about me, just because I do the work doesn't preclude me from the work, doesn't make me immune from the work. And the people who have read Hungry for More, who have not had troubles with their weight, have said to me, wow, like this book, and I always say this, the subtext is weight. It actually has nothing to do, our hungers have nothing to do with our weight, because the hunger, which really represents our unmet emotional, psychological, spiritual needs, are universal. Whether you're overweight or not, whether you're successful or not, whether you're a mother, you're a father, you're a CEO, an executive, a stay-at-home mom, the hungers are the same.
Right.
They are the unmet but very necessary emotional needs. And what if we were to look at this from the lens of opportunity instead of the lens of shame? Instead of suppressing our hunger, instead of being afraid of our hunger, what if we acknowledged that the fact that we were soothing with food or with smoking, alcohol, overworking, and ones that are actually societally, they're norms, right? So nobody would shame you for overworking and being successful as a result of trying to suppress that hunger for validation, hunger for approval, hunger for belonging, right? But what if we leaned into that hunger and recognized that what we were soothing by whatever dopamine choice
take your
mechanism, right? As a invitation to lean into that hunger, to explore what it is that it's really asking of us.
Right.
What if instead of going into the pantry or grabbing a glass of wine, we recognize that the partner that is sitting next to us, we are disconnected from. And we use that opportunity to put away our screen and turn off the TV and actually connect. To address that hunger in terms of the relational piece that is missing. What a beautiful opportunity to use what could have been shamed as a way to acknowledge what you are missing in your life and an opportunity to meet that need. And so my whole concept of hunger is rooted in self-compassion, is rooted in agency. Because if we can strip away the shame from that hunger and just use it as a guidepost to what it is that we actually need and to meet that need, then we give ourselves the opportunity to fulfill ourselves in a way that is so spiritual, emotional, mental, relational, and wholehearted.
It's like that. Are you gonna use the stick to measure with or to beat yourself with? You get to choose what you want to do with that stick.
And it is a choice.
It's absolutely it is a choice, and I think we need to be reminded that it's a choice.
I agree with all of the societal biases and genetic, all the things, right? There's so much input that shapes us. And I want to be very sensitive to that. But I also want to give people back their autonomy and their agency. Ultimately, we choose how we allow those societal narratives, those familial narratives, that backstory. We get to choose how we allow that to affect us. And, again, if we approach ourselves with positive self-acceptance, when we approach ourselves with this lens of self-compassion and strip away the shame, then we allow ourselves the opportunity again to really meet ourselves where we're at. And that's the whole work here, right? That's what we're here.
That's
this
the
journey.
Nugget of it. It's the real crux of it. I think the other part of it for me is it's different strokes for different folks. Some people do really well with an app. They take a picture, they count their calories, they lose a few pounds, they're happy, it works. Some people need in-house eating disorder clinic because they really need to go in and address it that way. Some people use a 12-step program to deal with the addiction of food or what they're doing with their substance. Some people reach for religion or spirituality. Some people use a dietitian. Some people go to a doctor. I would love if we could move away from it has to be done a certain way and bring it back to agency. Because for one person, it's 20 minutes around the block. For another person, they love to go to CrossFit. I don't know. I'm not promoting CrossFit, but I'm just saying, I think part of our jobs as healthcare providers is it's up to me to show you the buffet of what's available.
Absolutely.
And it's up to the client to say, you know what? not that one, not that one. This one, maybe I'm sort of open to it. And then together you can tailor make with some hand holding. I mean, I can tell you recently, I would get that like 4 o'clock, give me a chocolate croissant and
I
an
call it the
espresso.
witching hour.
It was so bad. I could be driving on anywhere and I would just pull into a bakery. And it was like, I need a muffin and an espresso now. I need a latte and a chocolate. It was so bad. So I stopped eating the pastries and the cookies and the ice creams and that afternoon weird thing. And my weight started going up. And I was like, I'm not eating sugar. I'm not eating those things. I'm not eating baklava, for the love of God. Baklava is the food of my people. I'm not eating it. And my weight is going up. What is going on? So in this phase of life, I had to take a look and ask a nutritionist, like, hey, can you help me with this? And she said, sure. Let's give me a few tools. Took the whey protein and started adding it. We need more protein now that we're in menopause, premenopause, whatever. And I was arguing with her. I would send her stuff and she would give me a recommendation and I would be like, no, but, and she finally wrote back. She said, and she'll be a guest on the podcast at some point. She said, Atusa, you have come to me for help and you are not taking my direction. Please give me a chance. And I was like, darn it. Maybe I'll try what she was saying. I kept telling her I was hungry. I was like, but I'm hungry. But my blood sugar dropped. But I'm hungry. And she finally said, Atusa, it is physiologically impossible for you to be hungry right now. I'm looking at what you ate. I'm looking at how many minutes and hours it's been. I'm looking at your food throughout the day. Right. There is something else going on. I'm going to ask you if your hunger is possibly related to something other than being hungry. Later that day, I listened to your podcast. Mm-hmm. And I was like, okay, I'm seeing a theme here. And when God sends me something like twice in one day, and what you said was, what if we learn to put food in its right place? And I loved that you said that because I'm a Virgo. I like labels. You all know I love my label maker. I love compartments. I like things to be orderly. I also have this British upbringing, so things have to be orderly. But my food wasn't. My food was the only place that it was like, let me get messy. Let me get messy. Let this be messy. I don't want this to be orderly. I don't want this to be orderly.
There's also a lot of physiology behind, I mean, the way we use food when it comes to difficult emotions or our unmet needs.
Yeah.
To call it emotional eating is really not doing it justice.
Yeah, it's not enough.
Because we know that, so now everybody is aware of, these GLP-1 drugs or glucagon-like peptide, which is essentially a mimic of a normal satiety hormone. When we eat food, the food goes down into the gut. The gut will release a signal to the brain to say, hey, we got food down here. You can turn off that hunger signal.
We're good.
That's a satiety signal, which is what GLP-1 is. And it makes sense that our hunger hormones or our satiety hormones both are going to respond to nutrient intake, right? You don't eat, hunger hormone goes up. You eat, satiety hormone goes up. What we have found, though, is that when people experience stress, when they experience difficult emotions, that literally the very hormones that signal hunger when people are fasting will go up even when you are fed.
Oh, wow.
And so there's this very physiologic drive towards emotional eating or eating when we're feeling difficult emotions or distress. And so I say that because it isn't so clean and neat. There are physiologic issues and therefore physiologic or very concrete recommendations like increase your protein. That increases your GLP-1, your body's endogenous GLP-1. But then there's also this kind of, esoteric space where it's like your social, emotional contribution to your hunger. And so it does take kind of having this multi-pronged approach.
Yeah, it's multifaceted.
Not only in terms of how we address it personally, but also how we address it in terms of the tools that we have, whether it's just diet or exercise and lifestyle, whether it's coaching, whether it's medications, whether it's surgical treatment for weight loss. I advocate for that in the right candidate at the right time as well.
Right.
And so again, it probably takes us back to just that open-minded, open-heartedness.
For sure.
Meeting yourself with curiosity and allowing yourself to make use of the resources at your disposal, whether they're medications or surgery or what have you, without shame. And to have your own personal agency as well, right? To be able to step back and say, what is it that I actually need right now? What is it that I actually want right now? And what am I open to in this moment in time?
Yeah. I have a friend who's recovering from bulimia, and she always talked about she hasn't thrown up or gotten rid of her food in over 30 years. But she talks about she loved feeling empty. She's like, I just didn't want to feel full. It was such a scary feeling for me. I had to get rid of it. I needed to feel empty. For me, someone was describing, they were heavy and they were talking about their relationship with food. And they said that when they sit on a couch, they like to put their toes under the couch cushions because the weight of the couch cushions makes them feel really safe. And when they eat or they overeat and they overstuff and they get that loaded feeling, they feel safe in the world. And I thought it was such an interesting contrast because for me, when I started working with this woman, I hate being hungry. I am afraid of hunger. I will avoid it. It is absolutely terrifying to me. And how interesting that in one person's body that feels safe, and in one person's body it does completely the opposite. Like I will get that first hunger signal, and I don't just go, I'm starting to get hungry. I have strobes and lights and alarms and things that go off in my central nervous system that say I'm going to die. And as far as I know, by the grace of God, I have not wanted for a meal or food or starved in that way physically, maybe emotionally at some points in my life. And so this lady said to me, what else is going on with this hunger that you're having? And my daughter even said to me, she said, Mom, I don't know anyone in the world who gets hungry like you. She said, you get hungry and you panic like the world is going to end if you don't get a meal in the next 5 minutes. Like people get hungry. They're like, oh, I'm hungry. I'll go have dinner. Or they get a little hangry. You get panicked. So for me, once I realized that, I was like, okay, all right, how do I mitigate this? What do I have with me? Even if it's 12 almonds, even if I carry the powder in my bag sometimes, because if it's taking me through a meal, mix it with a little water, drink it. And I'm like, okay, I'm not going to die right now. I'll be okay.
It's interesting because hunger is kind of it is a threat to our
It's a fight or flight, right?
It is a threat to our survival.
Yeah, but so finely tuned for me.
And it's so interesting because I turned into this mind-body work.
Yeah.
Which is kind of a side, but it's related. Because of all the reactivity around us right now. Yeah. All the turmoil, the geopolitical turmoil and what's happening in our streets, in our college campuses, and again, in our politics and in our global community.
Yeah.
And it's interesting to me that hunger, is a form of reactivity as well. That is also grounded in our nervous system. So the same way that we pick up threats around us that is rooted in our evolutionarily speaking, to our survival.
Yeah. Sounds and smells and things like that.
Well, now it's like your Instagram feed or the people you work with or financial instability or insecurity or, there's so many levels of these threats or stressors that trigger that same fight or flight sympathetic response.
Right.
That hunger also triggers, because if you didn't get food, then, historically, we would die.
We would die.
And I want to use this just to segue a little bit into the mind-body practices. Because the question is, okay, we can talk about this hunger until the cows come home. Yeah. But one of the questions that I was asked by a lot of people who read the book or listened to the TED Talk was that, okay, this all makes sense, but what if I don't know what my hunger is, right? Like, what if I don't know? And that takes us back to kind of our own knowing, our own inherent knowing, our own internal wisdom. And it is so hard for us in this day and age to access that. One, because we do have so much noise coming at us in terms of ideas and opinions and judgments, but also we have so much noise coming at us in terms of distractions, etc. And so what the mind-body practices do, which are basically practices that give you pause. They're practices that allow you to have this space between the trigger and that habitual reaction. When we can cultivate that ability to pause, right, to be still, whether it's through breathing, meditation, journaling, nature practices, sound therapy. I mean, there's so many ways to access this, and one size does not fit all. But the ability to pause allows us to connect back to that inherent internal wisdom. Because I do believe in doctors and coaches and gurus. Yeah. I wouldn't be in practice if it weren't for that.
Absolutely.
But I also believe in a time in which you shut off all the external noise and you dial into what we inherently know. Because only you know, and we all do know, what is the next best action? What is the next best step? What is the next thing we need to do, whether it's for our physical health, mental, emotional, relational, professional health? We all have that wisdom inside of us. And mind-body practices is a very accessible way to learn to cultivate that again, particularly in a world that is so noisy.
Let me fire off some rapid fire questions. I myself know that the GLP drugs have been on the market for a long time and used in many different ways for diabetes. And I know there's metformin. Is that also a GLP? Totally. How does metformin work?
So metformin is an insulin sensitizer. It does help the body's insulin production.
Okay.
And it has historically been used off-label for weight loss.
Okay.
But the results in the studies, and they always do this in kilograms, is like 1 to 3 kilograms, which is like at most 6 pounds. I personally have never seen that benefit in almost 20 years, even of 6 pounds. The GLP-1 drugs are by far superior in terms of their efficacy. I mean, you can't even compare to the effect of metformin.
Here's what I struggle with the GLP-1 drugs. And I talked to many physicians who say, Atusa, the risks of obesity are so much that even if we don't fully know the risks of the GLP drugs, we're still better off using them, because for many people, the risk of the obesity is causing so many confounding issues that you're better off with the GLP drugs. I struggle because we don't have huge randomized control studies of what these GLP drugs are doing over time. And it's been my experience that in 5 years, they come back and they're like, you know what, maybe those GLP, maybe the fen was, maybe the HCG. So what's happening?
We do have large randomized control trials.
Over time now?
What we don't have is the longevity.
The longevity.
However,
correct.
These drugs did not come around 3 years ago when the Kardashians started using them.
Right.
The first GLP-1 drug was actually FDA approved in 2011, and it had a decade's worth of data even prior to that.
Wow.
So they're not as
not that
new as we say.
Right.
That being said, they haven't been around for 50 years. They haven't been around for 80 years.
Right.
And so, and as more people use them, definitely more things will come to light. But more beneficial things are coming to light as well in terms of cardioprotective benefits. They protect the kidneys, tremendous cognitive benefits.
Right.
So now they're finding that not only is it impactful or helpful in cognitive decline in Alzheimer's, it's also helpful in terms of addiction, not just food addiction, but alcohol use, nail biting, compulsive shopping. People are reporting like more ease in general. So it's not an antidepressant,
Right.
but kind of taking off that edge.
Impulsivity almost.
Exactly. Taking away the ruminations, the obsessions, the impulses. And so I think even I am moving away from, and I used to always say, there are so many risks of obesity that we have to be mindful of when we think about drugs.
Yeah.
I would even say forget that, because there are many people who are overweight who will live long lives and who will never suffer a complication of having excess weight.
Right.
What we're finding, though, with these drugs, though, that there are quality of life measures that are so above and beyond that perhaps, not for you maybe, but for an individual out there, outweighs that quality of life benefit, outweighs the potential risk, which may to some degree be unknown, but it is not as a wild, wild west as it is being painted to be. And the last thing I will say is this: where is the bias there? Because if we had a drug like Eliquis for the heart that came out at the same time as the GLP-1s, roughly, we wouldn't argue about it as much. The cardiologist says this particular drug for, blood clots or another one for blood pressure is recommended. When we have hundreds of drugs that treat blood pressure, we are still open to the latest, newest drug for blood pressure.
Right.
But when it comes to obesity or excess weight, ultimately, the belief is that if somebody is strong-willed enough, that they can manage this without medications, and therefore no degree of risk is acceptable. And that is rooted in bias, not in reality.
Because I'm a midwife, I want to know, what are the effects of fertility? And are you seeing on fertility of these GLP-1 drugs? And are you seeing better outcomes in pregnancy and some of the complications that arise in pregnancy because of obesity?
So I can tell you that these drugs are resulting in levels of weight loss that are comparable in some cases to surgical weight loss.
Wow.
We have much longer term data from bariatric surgery than we do from the GLP-1s, for example. Yeah. And we know that the risk of complications of pregnancy, of preeclampsia, of preterm labor, of GD,
gestational diabetes.
Correct, gestational diabetes, of having a larger child, so all of these things are reduced when people who have obesity engage in successful weight loss. Mm-hmm. We also know that fertility improves as weight goes down, whether somebody is diagnosed with PCOS, which is associated with infertility and excess weight, or not. It does make people more fertile. And we don't know this information yet, but when we think about the epigenetic factors, when we know that a mother's diet impacts the child's likelihood to crave sweets, for example, or the child's desire when they're an adult to exercise, even that can be affected by maternal behaviors while the child is in utero. Yep. The implications of this are really far-reaching. So, again, I am an open-minded Western doctor. Yeah. I value medications and pharmacotherapy. I don't believe it's for everybody, but I'm really excited by the advent of these drugs.
Can you tell me some of the side effects or the downsides?
So, of course, this is a gut hormone that helps, like we said, regulate appetite.
Right.
So it makes sense that the side effects would be related to the gut. Nausea, vomiting, reflux, diarrhea, or constipation. To be honest, I can count on one hand the number of patients that I had to bring off this drug for GI side effects, because for the most part, they can be managed with diet. The issue with these drugs is the kinds of foods that would make you feel yuck anyway.
Right.
With this drug, it's like a slap on
Double,
the
yeah.
It's a slap on the hand. So there are GI side effects. They're not usually harmful. They're annoying and they can be avoided. That being said, one of the effects of the drug is to reduce gastric transit, slow down the gut. It's doing that on purpose, right? But if it's excessive, then it can cause something called gastroparesis, which is excessive slowing of the gut to the point that the gut is just not moving. Again, this is something that I think, and again, I don't have data to back this up, but I think there's a lot of prescribers out there, physicians that are not certified in obesity medicine. They don't understand the drugs. They're not doing the dietary counseling. Right. They're giving people higher doses. They're not titrating it appropriately. And if you jump to a higher dose because the patient's not responding the way you want, without understanding what this drug does and how you're supposed to use it, you're much more likely to develop gastroparesis or sudden vomiting, because you have not managed the drug properly.
Right.
Again, I've been prescribing this drug, for years. I advise my patients of the potential consequences.
Right.
I've never seen that. Now, there are some more serious potential side effects: pancreatitis, thyroid tumors. Again, these are also things that we've seen in the case of pancreatitis. It appears that diabetics are more prone to having it because diabetics are prone to pancreatitis anyway. And what we've seen in animal studies in terms of the nodules or the thyroid nodules, we're not seeing that in actual humans.
Interesting.
But the possibility is there.
Okay.
And so I advise people of all of these potential consequences. And again, it's an individual choice. If your risk of developing diabetes or obstetric complications or sleep apnea or osteoarthritis is X with having excess weight, and then the risk of developing this other complication is 1 in 10,000, 1 in 50,000. It's up to the individual.
Hey everyone, producer Josh here. Unfortunately, this is where my camera decided to run out of battery, but we have the rest of the audio, so please enjoy the rest of the episode.
Can you take it during pregnancy?
We don't recommend it during pregnancy or lactation.
Okay. So a person who's on it would stop. How many months before do you have to stop?
There's no strict guidelines. I usually like a 3-month washout with any medication. So I wean them off, have them be off of it for 3 months. I have a lot of IVF patients who come to see me for pre-pregnancy weight loss.
Right.
And I've had many patients who we've bridged them to IVF. They've had successful pregnancies. They breastfeed. They come back. We pick back up where we've started.
Amazing. And with the breastfeeding component, we still don't know the effects on lactation and how much actually gets to the baby.
Correct.
Got it. Let me end with this because I love this so much. We're going to end with a quote from your book, which is, quote, "No one loses 65 pounds to the sound of blaring trumpets. Arriving would mean our work is done, and we all know that our work is never really done." This hit me strong because once you lose your 20, 30, 40, 140 pounds, you're actually going to have to continue doing what you were doing, which for me, it was like, don't be so obsessed with what the scale is doing, because even when it hits whatever that whatever number is, it's those permanent changes that are going to bring the results, right? And so what if the blaring trumpets were actually blaring all the way through the journey and not just at the end?
Nobody builds a multi-million-dollar company and then sits back.
Right.
Nobody studies and gets 3 degrees and then does, fails to engage in continuing education.
Right.
Nobody gets into a loving relationship and then says peace out to their partner.
Right.
Anything that is worth our time and effort is worth our time and effort.
Wow. I feel like I could sit with you all day and talk about so many different things, but this what you talked about, the glucagon and the fight or flight and the hunger, and that's related to inflammation in the body too. Now I'm thinking they're all related, right? And the guest before you was speaking about menopause and some of the data that is all about inflammation, which doesn't just pop up in menopause, right? We know that people who are exposed to trauma or over and over and over again, that allostatic load increases their inflammation, which makes them more prone to certain diseases, including obesity and issues with weight. Where can we find you, Adrienne?
Well, all of my things are probably or are on my website, dradrienneyoudim.com.
And on our show notes, by the way.
And so you can find the book there. You can find the podcast called Health Bite. The TED Talk is there. I have a newsletter where I talk about my musings around these issues. And again, it's really, the weight is just something very superficial. The work is something that's so much deeper.
I'm honored to have you here today. Thank you for your time.
Thank you.
Thanks for listening to the Mamatoosa podcast on the Industry Plant Podcast Network. Mamatoosa is hosted by me, Atusa Benji, and produced by Josh Stretton Carlson. Our theme music is composed by Mary Lalazarian. If you enjoyed the podcast, please consider leaving us a review and subscribing. See you next Tuesday.